right, good morning, everyone. Thank you for joining this morning's academic meeting, which is sponsored by Sandoz. So, normality is defined as the absence of abnormalities, but even within that, it's difficult to define abnormalities. I think in medicine, we're also moving towards questioning the reference ranges that we use and looking to maybe redefine it in terms of particularly of race, ethnicity, but also regional changes. And I think we in pulmonology are also looking towards that. It's been indoctrinated in us since medical school that any lung function must start with the patient's age, gender, height, weight, and ethnicity. But even when that, we're starting to question the validity of ethnicity and race in determining the normal values for lung functions. And our speaker today is going to elaborate a bit on this. And our speaker is Dr. Erica Shaddock, who is a senior pulmonologist in Charles Matreke Johannesburg Academic Hospital. Her interests include COPD, PCP pneumonia, post-COVID and post-COVID lung disease. And she was also instrumental in the establishment of the WITS Internal Medicine Women's Association. So Dr. Shaddock, the floor is yours.
Morning, everyone. Thanks, Viv. So what's a bit different about today's presentation to what I usually like doing is there's quite a lot of words on the slide. So apologies for that, but there really isn't any other way of getting this information across to anyone. All right, so let's go. Sorry. I will figure out how to use this one. Okay. So what we know so far is that lung function tests they're critical in the field of pulmonology with regards to making diagnoses, and assessing normality within the respiratory system. And, when you're working in pulmonology and you don't have one, you almost feel like you're a soldier going into battle without a sword. But the thing with lung functions is to have the correct interpretation of the lung functions, we need to compare them to an appropriate reference range. And that's where it's probably a little bit different to, say, an ECG, for instance, where we all know this is what an ECG looks like. So without an appropriate reference range, we're not able to make good comments on what we're seeing. So this is from 2018, quite a good article where it has established what they particularly thought was relevant for factors that affect the reference range for lung functions. And you'll see here that both position and ethnic group are listed, okay? So just a comment on position, there is a lot of debate over whether patient's height should be standing or sitting. And it does look like if we take sitting height, we may be able to get around some of the other issues. But unfortunately, we don't take the heights of our patients sitting. We take them standing. So this is one of the controversies. And obviously here, whilst we don't include weight in the reference range, it does have an impact. But as you can see very clearly here, ethnic group. This was the last time both the American Thoracic Society and the European Respiratory Society came up with guidelines telling us what to do with lung functions. This is from 2005. And they said that the patients should be asked to self-identify their race or ethnic group, and that race and ethnic group specific reference equations should be used wherever possible. And then if that wasn't possible, that you didn't have your specific race or ethnic group reference range, you must then have an adjustment factor. And what they suggested for Black patients, or subjects as they called them, was that it would be less than 12% of the total lung capacity FEV1, FVC of the white patients. So this is very clearly stated in that document. What do the South African guidelines say? This is from 2013. They say that the patient's gender, age, race, height, and weight must be recorded on the day of the test. And of these variables, particularly gender, race, and height are relevant and are required for reference purposes. They then go backwards a little bit and say, oh, we must take race into account, but if you don't have a race-based system, then you must use the European Community for Steel and Coal Workers. And here they say without racial correction. So here they're telling us it's important. And then over here, later on in the paragraph, they say, oh, no, don't worry about it. And my question is when you do a UNE or a LFT or a thyroid function, are you checking your patient's race? The only one really with regards to gender would be your full blood count that has any gender components in it, but nobody takes into account any other demographics when they're looking at biological tests. And the bottom line is that race is actually what they're wanting to call a socio-political construct and not actually a biological construct. So hopefully by the end of this talk, I will answer some of the following questions. So, is using race in lung function interpretation helpful to the patients in a clinical setting or in research? Does normalizing the lower pulmonary function that we find in non-white groups mask possible modifiable social factors and other contributing health qualities? Or does ignoring race result in some non-white patients being denied certain treatments because it's regarded as too risky, because now their lung function is coming out lower than the expected? So this is, of course, very topical. And if you do a PubMed search looking at pulmonary function tests and race, this is what you would see. And it's becoming a massive talking point in the pulmonology community. So where did all this begin? Always important, I think, to look back for how we got here. And I think that's the problem, is we just assume that the reference ranges we've been given were appropriately done. And you'll see that they weren't. So here is a good English lad. He was a surgeon who had a whole lot of interest in equipment. He was John Hutchinson, and he invented the lung function machine. This is the original picture of one, obviously ridiculously bulky, and not something we would be able to take around with us. And he termed this whole term spirometer or breath measurer. And he also came up with this concept of vital capacity, which we still use today. And I quite like, if you actually look into the origins of the word, this is the capacity to live. And as a pulmonologist, I think that's obviously very important. He then did his research, and he suddenly found that actually you could use lung function measurements to predict early or premature mortality. And he thought his instrument would actually be used in the insurance industry with the actuarial scientists. And he kind of also thought that maybe it would be useful to diagnose tuberculosis. So these are a list of his original 2,130 participants. And if you think for a study that's done in the late 1800s, I think that's quite an impressive number. And eventually he had over 4,000 subjects. But obviously, being the 1800s, you can see how, terms we would certainly not use today are being used to classify patients or people. And obviously this girl's over here, which is 26, that's how many women he included in his sample of 2,130. He then concluded that vital capacity should be considered based on the following criteria: height, weight, age, and then by the disease the patient had. And today we still have height and age in the equation. Obviously, because he did not have a large enough sample size of girls or women, he was not able to pick up that there was a gender issue as well. Nowhere is there race in his original group. Again, a nice curve that we normally see, and this is from his paper, where you can show that the vital capacity increased as the height increased. And that's obviously what we expect today, and that makes sense. The taller you are, the longer your thorax is, the bigger your lungs are. So how did race get dragged into this? Well, we have this more recently controversial figure of Thomas and Jefferson, who decided that all men were created equal. However, he proposed in a document that the differences in pulmonary function based on race suggested a different structure in the pulmonary apparatus between black slaves and white colonists. So this is when this is his stance in 1785. And obviously later, now we have the lung function equipment that Hutchinson has developed, and people were now able to put what his thoughts were, what they thought, into practice. So this is Samuel Cartwright, a slaveholding physician in New Orleans, who studied using Hutchinson's machine and compared whites to enslaved Black individuals. And he concluded, and this is obviously in italics because it's his word, so point to a person where respiratory apparatus is so defective that they have not sufficient industry and mental energy to provide for themselves. And a lot of this data was actually used later to argue against the emancipation of the slaves in the US. No, their lung function is not good enough. They can't look after themselves. They have to stay as slaves. So this data was not only used in a medical fashion, but also in Congress. And he thought the deficiency in the Negro was 20%. And by using the word deficiency, he started to establish the difference in lung function measurements according to race, originally in the US. Then this astronomer got involved, and he was tasked by the US Sanitary Commission to go and do this massive study at the end of the Civil War in the US, comparing obviously various different races. And he devoted an entire chapter describing what the lung capacities were and how different they were according to race. And then, without any adjustment for height or age or any attention to anybody's work and living conditions of the newly emancipated slaves, he reported that full Blacks had lower lung capacity than whites. And the great difference of the mean volume found for the Black race from that which seems to belong to the whites cannot fail to attract attention at first glance. And again, a table where we are very clearly differentiating and using terms we would not use today. So this Malutu term that they're using over here is somebody of mixed race. Unfortunately, South Africa has a connection as well involved in this. I could spend another hour discussing the problems with regards to silicosis and the South African government's at the time and ongoing, lack of support for the South African Black miner. But the lung function equipment then became a valuable tool in the compensation process that became quite a big issue in the early 1900s and then into the 1950s to the 1980s. And in all of these documents, the words white miners are used versus Black laborers. They then were interested to see if there was a way to differentiate between silicosis and TB. And that was their argument the whole time with the lung functions, was that the Black laborer only got tuberculosis. And as soon as they picked that up, or any kind of abnormality in the spirometry, the Black laborer, for health and safety reasons, was repatriated and then obviously lost from view with regards to what happened to his lung function. Whereas the white miner was given the benefit of the doubt and was diagnosed with silicosis. You'll see this term often come in literature there called borskwal, and it's obviously Afrikaans, so the kwaad of problem of the bors. But this is what they are referring to in the literature of the pulmonary disability. We do have one shining light, and it's this lady called Margaret Becklate. She was a Wits-trained doctor who went to the the UK to travel to train in Hammersmith, and then came back and helped set up the original TISIS boards and SIMR, which was responsible for doing groundbreaking work in the 50s and 60s, trying to show that there was a significant lung issue in our miners. But she obviously very quickly got tired of the system and ended up immigrating to Canada, where she completed all her work later on. In the 80s, this particular doctor, who's from UCT, and this was published in one of the South African journals, did try bring up this issue of, is it ethical to have different standards on lung functions? But he was quite loudly shouted down, and nobody followed up on this information. So how does the race correction actually change the numbers we see? So here is an article that's from 2020 in CHEST, where they wanted to address, does race have any impact? And so I want to show you how on a, if we look at a community or a large population size basis, it doesn't seem to matter whether you race correct or not, but when you start looking at the individual patient, it does. So in this graph in number A, these are white patients at the top, and this is obviously the average as we age, with, again, Northwest Asian at the top and Southwest Asian and Black at the bottom. Now, if you take this graph and you superimpose it on this graph, this is the scatter plot of all the white patients. And you can see that while this is the mean, overall, they all fit into the same group. But if you look at an individual level, these are numbers from a 47-year-old woman who's 167.5 centimeters tall. If she's white, without, and this is the Geely group, which is one of the better groups, which does have race differentiation as well. We expect her to be 3.78 FVC or FEV1 of 3.03. But now she's Black, and immediately we decide that 2.61 is where she should be, and that only at 1.99 would she be in the lower centile, whereas if she had been white with a number of 1.99, she certainly would have fallen off the list. This led to a flurry of articles. This is what we call the Blue Journal, which is one of the very big American journals that we use in pulmonology. And these were the articles in one particular journal that was published, and this is published every 2 weeks. So obviously they collected them all, and here were the different articles looking at race. So I just want to look at a few of those. So this group was asking that, does racial ethnic-based spirometry help to predict the incidence of chronic lower respiratory tract infections and mortality, comparing it to race-neutral equations? And this was a very large population-based prospective cohort study of various race groups that was recruited between 2004, 2006, and they followed up patients till 2019. So again, quite a large group of patients, 3,344, relatively well spread across the different race groups, and luckily 50% female in this cohort. And this is what they found. So if you use race-based equations, the solid black line is where you would sit if you were where the normals would be for white, and you use race neutral, it shifts a bit to this side. And as expected, if you're Black, the exact opposite happens. So if you stay in a race-based approach, then the peak is in the same place. But without that, it shifts to the left. So obviously the norm is moved over and having lower percentage predicted. And as expected, again, the Asians also move over this way because there's the same kind of race correction. Hispanics behave quite similarly to white patients. So that's what we expect. They then looked at the prediction of lung events, which is what these two are, both FEV1 and FVC. The red is, obviously the solid line is the mean. The dash kind of shaded area is the range. Red, race corrected, blue, race neutral. So just kind of giving you a picture of where they all compare. This is mortality, okay? So they kind of just sit on top of each other, maybe just shift it over. But when you go and do statistics on this, and you look at the hazard ratios comparing, was there benefit with either at predicting mortality or lung health, your p-value becomes insignificant. So it doesn't matter if you're trying to use this to predict medical issues. You don't need to use race adjusted. It's identical. This is another big group and quite an important group, which recruited from 1988 to 94, and they collected mortality data till 2015. So a massive subset of over 12,000 patients were used. And obviously they were comparing all the various lung equations we have in both a race neutral and a race adjusted cohort. So what they found, obviously they had, again, their large cohort, mostly white. These are the patients who died. This is their age range. They found that on average, the Black participants were younger, more likely to be female, more likely to be active smokers, and more likely to live in poverty. And this is what they found. So they, on average, and we're talking liters here, not in the percentage of the predicted, the Black participants had lower FEV1s and FVCs compared to the white participants. So that's what everybody has been saying all along, all right? And the race-specific equations resulted in them having higher FEV1 Z scores or percentage values, the Black patient then using the multiracial approach. And again, the whites would shift. Now, that's what we all know. But what's important is that the higher FEV1 and FVC, again, the absolute numbers and not the percentages, were strongly associated with reduced mortality. So not the percentages, the actual numbers. And every time you moved up a Z score in improvement, you had a reduction of 20% in your hazard ratio. So the race-specific equations yield lower prediction survivals for the Black patients than they actually had. And if you use the multi, all these fancy statistical things where you take race out, the graphs start to match. And that's what this shows. So this is if we use race-specific equations. Here are white and here are Black patients. And they're not matching with regards to their survival. But the second you take race out of it, they are both tracking the prediction ability for mortality. Again, if we take the full and proper FEV1. So it means that you can use your FEV1, and I'll show you later your FVC, to predict mortality on the actual number and not the percentage. Okay. So they're saying that if Black patients having lower lung functions was normal, which is what all the previous documentations have been telling us, you would expect those race-specific reference equations to predict the same mortality. But that's not what happened. You needed a race-neutral approach for the equations to work. And FVC and lung health and life expectancy was brought up originally with Hutchinson in 1864, when he showed that FVC predicted mortality. And unfortunately, it was the cardiologists in 1980 who, using their Framingham data that we all use and know well, showed that the FVC predicted cardiovascular as well as non-cardiovascular mortality. And this pulmonary function measurement should be used for both insurance and underwriting purposes. So again, nothing to do with the percentage over the predicted, but the actual FVC number will predict your death. Just so that you don't think all the research is leaning in one direction, this unusual study looked at genetic markers and used different single nucleotide, various ones that are associated with various races. And again, and they feel that this is obviously genetic, that the best fit for the white equation would be if your African ancestry was less than 32.5% and 32.8% for FVC. But the African ancestry or Black one would match you best. So the composite equation, so obviously the mixed one would work best if you were this amount mixed. And then if you were a pure, a person of Black descent of more than 78%, then you could use the Black prediction models. Now, I don't know about you, but now we're going to do genetic testings on everybody and figure out what percentage you are of what race to see which equation fits. This particular group of people felt that there were no longer technological limitations and that we should be using genomics in the pulmonary function lab, and that we should promote race consciousness medicine with regards to precision medicine, rather than a one-size-fits-all kind of approach. And the whole point is to be taking race out of medicine. That's really what has happened in the last 10 years. And somehow these group of people want us to put it back. And again, we'll look at a picture at the end. Lung function is not a determination of just what you're born with. It is a combined of everything that has happened to you. I kind of think about it as a road to lung health. Every step you've taken on that road from the time you've been born to the time you die is going to have an impact on your lung health. Were you a normal vaginal delivery or a cesarean section? Will have an impact. Were you premature? Did you live in a polluted area as a child? Did you have multiple respiratory tract infections? Did you smoke? These things all have a massive impact on lung function. And therefore, we can't just take one component of that journey, in other words, your genetics, and make a general rule about that. That same year, we had 2 other articles coming out looking at this as well. And just wanted to focus on this one because this one now starts to look at, rather than just mortality, the ability of your lung function to correlate with all the different things we use in pulmonary medicine. So your 6-minute walk test, your CAT score, the CT scan, your airway thickness. So this was taking the lung functions and adjusting for various races, and then looking at the actual clinical aspect of it. So again, a nice large group of 2,652. All these patients pre-reported their race, and then they did a lot of fancy statistics on it. And what they found was, again, like we've expected, that with race-specific equations, the white individuals came out with higher lung functions on a percentage predicted value than the Black patients. However, that if you use the gender ones, so the universally adapted ones, the patients of Black descent did come up with lower lung functions. But what does that matter? And the bottom line is that all of these clinical scores, which we know, work better with a race-neutral approach. And I'll show you the pretty graphs. So here again, we have the various regression models with the race-specific and the race non-specific. And the only time they start lining up is when you take race out of the equation. So if we take race out, we're able to determine whether the patient's CT scan matches their lung function, whether the air wall thickness matches their lung function. Because if we put race in, there's definitely a discrepancy between the two. And that's what they concluded basically here. So race-neutral equations help better to predict symptom burden, 6-minute walk test, and a very clinical radiographic airway measure. Now we're in 2023. This is a preprint, and the conversation still continues. Again, a massive study here, a lot. They use 2 cohorts here, the National Health and Nutrition Survey and the COPD gene study cohorts, comparing race-neutral, race-free, and race-specific equations, and using very fancy stats that I'm not necessarily going to be able to explain to you, various regression models. They applied these again to the population to see if they could align their COPD classifications and their CT scans and their dyspnea. And they found the same thing, that the race-specific equations showed no specific advantage compared to the race-neutral equations when comparing to CT scans, and that the race-neutral reference ranges would have reclassified 19% of the Black participants into a more severe COPD disease. And so what that means is that we are probably underdiagnosing diseases in our patients of color, because we are assuming that their lung function is genetically lower than it should be. This is also from this is also just the most recent American Annals of American Thoracic Journal. I'm not going to go, I just wanted to print the conclusion. So here they were comparing where you ended up on the lung transplant registry, depending on your FEV1. And that by using race-specific equations, the Black patients were disadvantaged and were sitting higher up. So we're less close to where they should have been given their transplants because it was interpreted that their lung function was actually 30% of normal, when in real fact it was 20% if we used race-neutral approach. Decisions during COVID that were not necessarily made here, but in the world, where you had to have certain saturations to qualify for high care or for ICU or for interventions. The patients, the SATs probes were overestimating the SATs in people of color. And then you go back and you look at the equations that were generated to for the fancy I don't know, computer maths that they calculate to see where, it all depends on the wave that is generated from the hemoglobin. And the original groups that were used for those were all white and were pretty much done 20, 30 years ago. So we are now having to recalibrate all our SATs probes in future as well. So there's definitely been a significant problem when it comes to respiratory health in regards to race. So let's go through the questions. So is race helpful interpreting patients set up in a clinical setting or research? Again, on a population basis, probably not. It doesn't make a difference. But if we are then going to allow decisions to be made on when patients receive treatment, or whether they should be placed on a list, it is certainly going to have an impact. Does normalizing the lower pulmonary function in the non-white groups mask the modifier associable risk factors and contribute to health disparities? And I think that's probably definitely true. We really should be looking at everybody's lung function with one eye and saying, well, if your FEV1 is 2.5, this means X. Or this means Y. So I think it does. Lowering them makes a difference. And this is the tricky one, because if we start going to race neutral points and we have cutoffs that you have to have an FEV1 of 30% to qualify for surgery, your patients of color are going to have lower percentages if we use race neutral approaches. So there is a chance that they would be denied certain surgeries because they look too sick to tolerate them. And therefore, we need to make new rules based on the actual FEV1 and the actual FEC rather than the percentage predicted. And that's to a certain extent what we do with our cardiology colleagues. You have to have an FEV1 of greater than 1 liter to come off a ventilator, for instance. So we do try and take the actual number rather than the percentage. So this is a bit tricky. But at the end of the day, there's so many different things that can contribute to your lung function along your lung health journey that I think we need to try and make one of them as simple as possible. We can't take into account what pollution everybody had as a child and where they are and how they were born and all these other things. So I think one of the things we can take out of the problem would be race. And so that's what I do. And that is seeming to be how the pulmonology literature is heading. And that's why I called it a Gordian knot, because who knows where this starts and where it finishes. It's obviously a very complicated process. And if anybody's interested further in reading up about this, this is a great book. It's it's not a medical book that explains the long process that has resulted in where we're sitting today, with race sitting on the list of predetermined things that we need to include in our lung functions. I always tell my medical students, it doesn't matter if my patient is a 65-year-old Black or white gentleman who's now presenting with ischemic heart disease or a CVA. The patient's race doesn't matter. And we need to not include that when we are assessing patients or taking it into account. Thanks, and I'll take any questions.